Welcome to the Affirming Minds podcast, where we equip like-minded mental health professionals with a therapeutic toolkit that helps add to a more engaging, fulfilled, and effective mental health practice. Each empowering episode can stand alone as a continuing education pod course or a very valuable professional or personal resource with insightful expert interviews, practical resources, industry news, and lots of inspiration. We help the modern therapist thrive at work. Now let's welcome your host, a dedicated therapist and passionate educator, Shayna Cyber, LCSW.
Welcome to the Affirming Minds podcast. I'm your host, Shayna Cyber. Before we dive into today's episode, I want to take a moment to share some important disclaimers. This podcast is for educational purposes only and should not be considered a substitute for professional treatment or clinical supervision. If you're in need of those services, please reach out to a licensed mental health professional. Confidentiality is always a priority. Any clinical examples shared in this episode are de-identified, composites, or clinical vignettes, ensuring that no real client or patient health information is ever disclosed. If you're interested in earning continuing education credits for listening to today's episode, visit affirmmentalhealth.com to learn more about our membership options. Our membership includes CEs for live virtual workshops, self-study webinars, and pod courses via the Affirming Minds podcast. Today, we're diving into a crucial topic: how we can reimagine eating disorder care through evidence-based multidisciplinary treatment while also addressing systemic disparities that impact access and outcomes. For too long, eating disorders have been misunderstood and misdiagnosed, particularly in marginalized communities. The stereotype of who struggles with eating disorders has led to underdiagnosis and lack of proper treatment for individuals in larger bodies, BIPOC communities, LGBTQ individuals, and those with limited financial resources. But the reality is, eating disorders do not discriminate, yet treatment access does. So how do we bridge these gaps? How can we move beyond traditional models and integrate medical, psychological, and community-based interventions in a way that truly is inclusive and effective? And what role does dialectical behavior therapy and family-based treatment play in supporting both individuals and families through the recovery process? To help us navigate these questions, I am so honored to welcome two experts in the field of adolescent medicine and eating disorder treatment. Dr. Alexis Richards is a board-certified pediatrician and adolescent medicine specialist dedicated to advancing care for young people with eating disorders, adolescent mental health concerns, and reproductive health needs. She serves as the medical director of the Eating Disorders Program at the Children's Hospital at Montefiore Einstein, the associate program director of the Adolescent Medicine Fellowship, and an assistant professor at pediatrics at Montefiore Einstein. Dr. Richards earned her Bachelor of Arts in Psychology from New York University in 2007 before completing her post-bac pre-medical studies at Columbia University in 2009. She then obtained a Master of Science in the Control of Infectious Diseases from the London School of Hygiene and Tropical Medicine in 2011. She then returned to the U.S. and earned her Doctor of Medicine from Emory University in 2015. She is actively involved in medical education, research, and advocacy. Dr. Richards' research focuses on sexual and reproductive health and eating disorders, with work published in peer-reviewed journals and presentations at national conferences. She also serves as a reviewer for the Maternal and Child Health Journal and is a fellow of the American Academy of Pediatrics and an active member of the Society of Adolescent Health and Medicine. Through her clinical practice, research, and education efforts, Dr. Richards is committed to improving health outcomes for adolescents and young adults with a strong focus on equitable access to care. Next is Dr. Lauren Yadlosky, PhD. Lauren shares this positionality statement with our audience. She is a white, cisgender, allistic, heterosexual woman from an upper middle-class background who benefits from able-bodied and thin privilege. Dr. Yadlosky is the clinical director of the Eating Disorders Program at Montefiore, EDPM, an attending psychologist within the Child-Adolescent Outpatient Department at Montefiore Medical Center. Lauren serves as an assistant professor in the Department of Psychiatry and Behavioral Sciences at Montefiore Medical Center and the Albert Einstein College of Medicine. Lauren completed her PhD in clinical psychology at Marquette University and her predoctoral internship at Montefiore Medical Center in child-adolescent specialization. She went on to complete a clinical and research postdoctoral fellowship at McLean Hospital, Harvard Medical School. Her clinical expertise focuses on high-risk, multi-problem youth, young adults, and families, particularly those struggling with comorbid eating disorders. She has extensive experience across outpatient, partial hospitalization, residential, and inpatient medical levels of care, and is trained in comprehensive dialectical behavior therapy and family-based treatment for anorexia and other cognitive behavioral interventions. She's committed to integrating intersectionality with psychological science and practice beyond her clinical work. Dr. Yadlosky's Research and Advocacy Center on Health Equity, Systemic Barriers to Care, and Improving Access to Evidence-Based Treatment in Underserved Communities. This is an important and eye-opening conversation, and I'm so grateful for my guests for their strong advocacy work and systemic focus. So whether you're a clinician looking to deepen your understanding, a parent or caregiver navigating a loved one's recovery, or someone interested in advocacy and systemic change, this episode is for you. So let's get into it. Lauren, Alexis, thank you so much for being here and joining me on the Affirming Minds podcast. I am just so thrilled to have you both here with me today. I think the work that you're doing is so important, and I'm really excited for our listeners to learn more about it. Maybe can we just start by having you each share a bit more about your professional background and what really inspired you to specialize in eating disorder treatment?
First of all, thank you so much for having us. So I'm Alexis Richards. I'm an adolescent medicine specialist, double board certified pediatrics and adolescent medicine. I first fell in love with adolescent medicine during my residency, where during my special electives, where I was really meeting teenagers and figuring out how I could be the best doctor for them. And after working for a couple of years after residency, ended up pursuing a subspecialty fellowship. And I ended up going to a program that was really a major referral center for eating disorder care. And so I had not been interested prior to fellowship in eating disorder medicine. And then just through kind of natural osmosis and meeting these patients and taking care of them and understanding more about the medicine, I fell in love with these patients, with this medicine, with this care. And it's just been a wonderful journey since then.
I love that. Lauren, what about you?
Yeah, I came through DBT. So I'm a little bit of a DBT nerd, I describe myself in. And some of my early training experiences in graduate school were with DBT patients and building an adolescent program for DBT. And one thing that I noticed was all of our eating disorder patients who had comorbid suicidal behavior, self-harm behaviors, emotion dysregulation, and eating disorders were being referred out. And so it was a struggle consistently because it was such a high comorbidity for us. And I was realizing that the eating disorder programs wouldn't take these patients because of their self-harming behaviors or their suicidal behaviors. And the DBT programs wouldn't take them because of their eating disorder behaviors. And our team didn't have access to the training to be able to do that at that point in time, and didn't feel like they had the training to be able to treat those patients in an ethical way. And so I was really interested in getting that training and actually came to Montefiore for my internship in my graduate training to get that specific training. And so then fell in love with it, similarly to Alexis, fell in love with it and then continued to create that co-specialty of being able to work with high risk folks with or without eating disorders. I think it's a challenging patient population, so it has a lot of the things that I was always interested in and have been interested in as a clinician. And then just these folks need care, so let's do it. And jumping on board. And also found that I think the folks who are also committed to doing eating disorder work are very similar in their approach to care and values and things along the way. And so that was how I ended up here.
Amazing. And it seems pretty apparent for both of you. It's a labor of love. And I think that always really shines through when people deeply care and are committed to the population they're serving, and they also enjoy it and get meaning from it. Yeah. So From your combined experience, how have you seen the field of eating disorder treatment evolve through your careers? And what stands out as the biggest change or advancement? I wonder, Lauren, if we can start with you, because I think you were already talking through some of those gaps you were seeing systemically and some of the ways you are now like clinically approaching those in different ways through program development and things like that.
Yeah, absolutely. I think one thing to name is that both Alexis and I are pretty early in our careers in this field and in the specialty. And so want to like very much acknowledge the folks who have been and come before and have probably greater perspective on some of those changes. And that being said, in the years that I've been doing this, I think we have seen some pretty significant changes. One other caveat is I think the research funding, particularly into treatment, identification of eating disorders, is really drastically sparse. And we're doing the best we can with what we have. And I think we're lagging behind other fields, particularly in terms of effective psychological interventions because of the dearth of research funding that has been provided for this patient population. But the things that are exciting, I think one of the things that came out of DSM-5 was the creation of the ARFID diagnosis. So that's avoidant restrictive food intake disorder. We love our acronyms in psychology. And so it's shorthandedly extreme picky eating for various reasons that result in medically complicated presentations and significant psychosocial impairment. And so that diagnosis came up. And so those folks have had this diagnosis for a really long time, but now we have a label for it. And we're pulling in other resources and to be able to treat that. There's lots of CBT that's coming out of that. We've got better assessments for ARFID coming out of that. We've got really good other adaptations of treatment for that, which are really excited. I think similarly, binge eating disorder, we've seen a lot of clinical advancements there. I think the approach has really shifted also, and this is larger, like zooming back, where I think a lot of folks are really viewing, particularly in pediatric work, parents and families being central to treatment intervention and care, whereas that wasn't the case early in the eating disorder world. Sometimes they would talk about the parentectomy and actually removing a child from the home environment. And while sometimes we do need that, I think a big push has been how to integrate families and how to get education in that way too. I also think we are making some better strides, especially for folks who have access to resources or insurance-based care, in recognizing different levels of care and being able to leverage levels of care and integrating more. I think this is where I hope we're going. And Alexis, please jump in. I know you have thoughts about this as well, of thinking about how weight bias really is built into a lot of our eating disorder assessment and treatment and intervention, and thinking about dismantling some of that as well, I think is hopefully that's starting and hopefully where we're going to continue to go.
Yeah, you touched on a lot. Alexis, can you maybe share with our audience a bit about that weight bias perspective and what you have seen?
Yeah, I think historically and even currently that there's a lot of emphasis in medicine about obesity management and the dangers of obesity and the risks that you have for longevity, morbidity, mortality. And unfortunately, a lot of that research and guidelines don't factor in, what does that actually mean, right? What does health mean? What does obesity, create in terms of risks for morbidity and mortality? And also, what are the risks that young people face when they're told over and over again that they are overweight or too fat and need to lose weight? And we're seeing the impacts of that, and we're seeing how really detrimental it can be to both physical health, but also mental health in terms of body image and then development of eating disorders.
Wow.
One thing I'll also add about where the field of eating disorder is evolving, it is about the players, the stakeholders that are involved in the care. So I think historically it was really siloed, and it was mostly falling under the realm of psychiatry. A lot of eating disorder patients were taken care of primarily by psychiatrists. And one of the things that we're evolving is a really beautiful multidisciplinary approach, where there's lots of other providers that are coming in to care holistically for these patients. And that includes social work, it includes nutrition, it includes psychology, it includes psychiatry, it includes pediatrics, adolescent medicine, and in internal medicine as well, to really be able to touch every part of these patients' lives, to be able to help them on their recovery journey.
Yeah, amazing. And how have you seen this integration of an interdisciplinary approach, medical and psychological disciplines working together? How is that translated into outcomes for the patients that you're seeing with eating disorders?
It's a great
I
question.
think, yeah, it's a great question. I think, and I've done eating disorders work in multiple places. And so I think one of the things, I don't have objective data on this, but subjectively, I think the more integrated a team can be and on the same page, I think the faster patients recover and the more holistically that they recover. I think one of the things that Alexis and I work really hard at the eating disorders program at Montefiore is to be on the same page, particularly with lots of things, but also with the ultimate treatment goal weight. And so that our families are receiving the same message. And we work really hard with our nutritionist team to also be delivering the same message and using the same equation to calculate that. So that when families are fighting an eating disorder, their treatment team is also on the same page and aligned together so that we can align with families against the eating disorder pathology. And so I think the more integrated and on the same page we can be, and similarly following through, and I'm always saying, look, I need you to be going to your adolescent medicine appointment. What are they saying? How are they complying? How can we help you get there? And I know a lot of our adolescent medicine attendings are also saying, we need you to be following through with the psychology team and going to your appointments. And that's equally as important. And it really shapes families towards a holistic care, which I think makes it a very difficult journey, recovery journey, somewhat less hard because there's more support and it's consistent and the messages are consistent.
Yeah, I think it would be an interesting study actually to look at outcomes depending on resource. I can tell you subjectively, like Lauren, like when I'm talking to pediatricians that are in more rural areas or don't have access to specialist programs for care, it's really a struggle and they're doing an amazing job. But if you don't have a psychologist and you don't have a social worker and you don't have a nutritionist who's there to provide some of that same messaging and be able to have more touch points with these patients, then there are some things that are just not able to be done, right? Pediatricians, we know, particularly general pediatricians in rural areas, have an astronomical amount on their plates. And so being able to have a multidisciplinary team who can pick up the different parts of the puzzle and put it all together, it's absolutely priceless.
Yeah, absolutely. And so interesting you're talking about getting everybody aligned. I think also that languaging of externalizing the eating disorder, that everybody as a family unit is not aligned with their child and working towards eradication of the eating disorder and separating those things. Because I think a lot of times there is so much internalization and it can probably be complicated if that's precedent is not set of how it's being framed from both the treatment team and the family and client approach. But also, just as you were talking about before, the weight bias, I have worked with clients and I primarily work with adults, whether it's bulimia or binge eating disorder. And I would say the majority of my clients that have suffered with eating disorders were not actually in underweight bodies. And I think sometimes when there was everybody working in a silo between medicine and psychotherapy, people were getting stuck strictly different messaging depending on who they were interacting with, and sometimes things that felt like they were working in contrast with some of the work that we were doing psychotherapeutically. So I feel like just that everybody is on the same page must be so deeply meaningful. And I could see how it really can accelerate things, because I have the experience of the opposite of feeling like, oh, okay, this is really inhibiting our progress and slowing things down and creating some challenges. Absolutely. Um, so I know, Lauren, you mentioned that DBT is so critical, particularly when people are presenting with these comorbidities or are struggling with self-harm or suicidality. Can you tell me a little bit about what role DBT plays in your treatment programs and how it's impacted outcomes for individuals with eating disorder in your experience?
Yeah, absolutely. So I think we know eating disorders. We talk often about the big three eating disorders. We talk about anorexia, we talk about bulimia, and we talk about binge eating disorder, the big three that we talk about most often. And I think it's helpful to acknowledge and just name that while we're talking about some of these more egosyntonic treatments or some of these things that of this being really challenging to treat, or to your point, like being really embedded, or sometimes patients aren't always, or they're at least ambivalent about getting treatment or fully recovering or hitting that treatment goal weight, that we do think about the different eating disorders differently and embedded within each patient's culture and each patient's own identity and experience. And so when we're thinking about integrating DBT, I think it depends a little bit on the case conceptualization and the diagnosis. And it can be hard when you're working with eating disorders to know, especially in the beginning, when there's still so much physiological dysregulation, of what's physiological dysregulation associated with being in a chronically semi-starved state or an acutely semi-starved state, or, and right, like that has nothing to do with BMI, that has nothing to do with being low weighted. It's relative to where your body wants to be. So folks who are in bigger bodies can be chronically semi-starved or malnourished and not at a low weight category. So I think that's something we really stress and talk a lot about. I think probably, I don't know, at least in my case, in our caseload, and Alexis and the adolescent medicine team see far more patients than we do just because of limited resources. I think more than 50% of our kiddos with anorexia are in larger bodies, above the 50th percentile for BMI, and have always been. So I think that's an important thing to keep in mind as we figure this out. I think DBT plays a really nice role in eating disorder recovery when there's emotion dysregulation that's driving the bus behind the eating disorder behaviors. And so that can be, there's a lot of evidence that it works really well with binge eating disorder and bulimia, especially with some of the impulsivity. If some of those behaviors are being driven by an underlying emotion dysregulation, I'm either guilty or I'm experiencing shame, and that's resulting in some of the eating disorder behaviors happening. I think the other big piece, and even where we may fold it in with, and sometimes, to back up, sometimes DBT is the only psychological intervention that's kind of indicated at that point, if it's really the thing that's driving the bus and we are navigating that and we're able to chain it and we're able to use all of our DBT strategies to help support that. In certain situations, we're not, it's not sufficient on its own, especially in our pediatric populations with folks who may need weight restoration or are in the anorexia category and may need weight restoration on top of there being an emotion regulation function to some of those things, which is when we might actually fold DBT in alongside a different eating disorder modality. And it's really important to be able to do both of those things at the same time, because one thing that happens in eating disorders, like the eating disorder will find the weak link. And this is where we talked earlier about the importance of your team all being on the same page. Of the eating disorder is going to find the person's, this person said that goal weight, so I'm going with that goal weight, whereas you said this one is this. And it works the same, I think, with potential problems. So I think sometimes what we see is we see folks, none of this is volitional, by the way, we see sometimes that folks will have spikes in risk or self-harm behaviors that stop the eating disorder treatment because now we have to focus on the life-threatening behaviors, right? And so then, boom, the eating disorder gets to flourish while we're either hospitalized for the psychiatric reasons, but then the eating disorder isn't really getting treated and spins over here. And then vice versa, if we're getting the eating disorder treatment, sometimes we see a spike in the self-harm and we can't move forward. And so thinking about DBT can be really useful, especially in those cases, so that we can continue to move forward in both directions and continue to say, okay, I've got one arm on some of the risk behaviors and we've got all of the structure and support that a comprehensive DBT program can provide. And one hand on continuing to drive forward and to not allow any of those potential problematic behaviors to pause the eating disorder treatment so that we can really move forward with both at the same time.
Yeah, that's really helpful to think about as you both are talking about sort of the values of the treatment approach in its totality. It sounds like it's really about more of these holistic approaches to care and moving towards treatments that can serve these transdiagnostic aims so that it doesn't have this start-stop disruptions to treatment. Sounds like it's like a sort of a really a part of the ethos of the program in so many ways, and you're doing it through the program integration and this multidisciplinary approach, but also the actual clinical approaches that are the core modalities, which is great.
Sheena, to that point, similarly, I'm a DBT person, so my bias goes in that direction, but there's a lot of co-occurring trauma that happens in eating disorders as well. And so the idea is the principle's generally the same. If we can actually have clinicians who can do both simultaneously, or when someone is weight restored enough to be appropriate for an exposure-based paradigm, that we're actually able to do those things simultaneously. So again, we're trying in the eating disorders field on the psych side as much as we can to get folks who have the ability to do both simultaneously, again, with that reason of wanting to be able to continue moving forward and not pausing the eating disorder treatment to target the other piece. But if some other pathology becomes treatment interfering, to be able to do those things at the same time. And trauma is another one that we're working to do that with as well.
Excellent. Another core clinical intervention that is being used by your team in terms of the psychotherapeutic side is family-based therapy, or FBT. And can you tell me, just maybe tell a little bit about like the core principles of the approach itself, and how do you incorporate FBT into your practice, and any challenges or successes you've seen with this model of care?
Family-based treatment for anorexia is the only empirically supported treatment for anorexia that we have at this point in time. I think that's an important thing to state. It's the only treatment we have right now that has demonstrated efficacy in terms of weight restoration. There are other treatments that can help prevent hospitalization and other things, but FBT is it that we have right now. And the core tenets of FBT are essentially that it's a stage-based model, like most often psych treatments are. And the first stage is really empowering caregivers and loved ones to take over the weight restoration process. And so we empower parents to feed their child and refeed their child. They're deciding, we make some very gentle recommendations, 3 meals, 2 snacks. Gentle's the right word. But we make recommendations and then really empower the parent to use whatever is in their toolkit already and whatever is their culturally appropriate foods to be able to do that. And so we will often orient parents, say, hey, okay, you did this before. I want you to think back to when your kid was 3 and they were screaming because they wanted the blue cup and they didn't want the red cup, but the juice was in the red cup and you needed them to finish the juice. How do you do this? And really working from a parent empowerment model to get them to think through their own skill set, for them to become the masters of navigating how to do this. And then once a child achieves that full weight restoration, we have a phase 2 where the teen is developmentally taking back control in slow steps, especially as they've learned skills and strategies to be able to more effectively manage the eating disorder thoughts and urges. And then we've got a stage 3, which is getting them back developmentally on track. Importantly, FBT is considered agnostic from a theoretical orientation, where we're not really worried about where this came from. We're worried about the now and moving forward. And we have a crisis, and this is in fact a crisis. And we know that the sooner we treat this and the sooner we get that weight restoration, the more likely we're going to be for full recovery and preventing relapse. And so we're jumping in. We don't care how we got here, but we're here and we're doing this, and we're putting it in the hands of the family. One other, I think, thing that I like is that as a clinician, you're actually seen as the expert consultant. And so you're providing psychoeducation and educating parents and giving them the tools and strategies that they need to be able to make some of these choices. And then you're testing them in real time. And we're shooting for 1 pound to 2 pounds of weight gain a week. And we're doing weekly weights to check that. And then we say, okay, parents, what choices are you going to make this week? What are you going to do differently? Okay, we saw weight gain. Great. What worked? Okay, we saw weight loss. What are we going to do differently this week to be able to adjust that? And then giving some additional psychoeducation along the way.
Yeah, absolutely. It was really interesting to hear about that process and those stages in terms of dealing with the acute crisis. Alexis, from your perspective, in this process of refeeding, what's important in terms of that interdisciplinary team approach?
Yeah, I think about at least the medical aspect to be complementary to the psychological approach, right? I practice what I call FBT informed care, which is really continuing to underline the FBT principles in my care without the training in FBT myself, but really when I'm seeing my patients, if it's meeting them for the first time or we've been seeing each other for years, it's really underlying that we need to shift the control right now over to the parents until we're in a medically and psychologically different place than we are now. And it's not easy. It is really different from how I practice adolescent medicine in every other area that I practice in, right? Adolescence is about developing autonomy. It's about self-identity. It's about becoming an emerging adult. And FBT-informed care is really, in some ways, feels counterintuitive to that, but being able to shift how you practice and what you know to be most successful and align with the other providers that are taking care of these patients.
Yeah, absolutely. Absolutely. Yeah, so one thing I think is so incredibly special about your program is the patient population that you're serving, and that in terms of access, in terms of health equity, given your services being centered in the Bronx, largely serving a payer mix that is on public insurance, Medicaid. So I'm just curious, in your clinical experience, what are you seeing as some of the most significant health disparities that are coming up in terms of the diagnosis and treatment of eating disorders?
I think we first have to talk about the historic understanding of what eating disorders were thought to be, which is, I think for a very long time, it was considered to be a disease of middle, upper class, Caucasian females. It used to be in the DSM that amenorrhea, secondary amenorrhea, the loss of periods, was part of the diagnosis. Now that excludes a very large population of eating disorder patients. And I think we are coming along from that. We still have a lot of work to do, thinking about how we're diagnosing, how we're screening, how we're thinking about patients that come from different economic, racial, ethnic, religious backgrounds. And we're doing it in real time.
And we know There's evidence that BIPOC folks are less likely to be screened for eating disorders, even if they present to physicians and clinicians with disordered eating behaviors or concerns. They're less likely to receive treatment. And so this is an issue. This is an issue of systemic oppression. And Alexis and I and the rest of our team think about it in that way. And so we are combating that eating disorder stereotype on both sides, right? We're working in the hospital system to provide education of, hey, that BMI number that you're using didn't include bodies of your patient. That didn't include folks from that age, that gender, that racial class, that culture. And so maybe that number may not be the most indicative of health status. Can we think about that in a different way? Can we think about counseling folks in a different way? When you tell a kid they need to lose weight, but are not thinking about all the systemic barriers that might go into that, culturally appropriate food, access to the foods that you think are healthful for them, caregivers' time to provide adequate supervision, to provide meal prep, all of those pieces, access to safe places to move their bodies in ways that feel good. Kids hear different messages. And this is true of adults too. I think one of the things that we're dealing with is the fact that a lot of our caregivers that we work with, and this is true regardless of anywhere I've worked in eating disorder care, caregivers also have a lot of that internalized weight bias because they've been told those messages for a very long time. And so I think when we're thinking about it, we also then have to think about our patients. So a lot of our patients will come in, or their caregivers will say, my kid can't have an eating disorder. That's for white girls. And so we are thinking about, sometimes we use different language. And so we talk about disordered eating or problems with eating to be able to engage with them so they don't think that they're falling into a category that doesn't apply to them. We also see a lot of gender differences in treatment too, and thinking about folks who may not fall into a gender binary. And how do we navigate some of those complexities as well, and the overlap between body dysphoria and gender dysphoria and some of those things as well. And so I think it's a lot about knowing that FBT was not normed or created for our patients, right? I think everyone on my caseload would have been screened out from some of those FBT trials. And so how do we get creative? How do we meet families where they are? FBT doesn't typically involve nutrition, and you don't actually need to be working with an eating disorder medical specialist, but we do that as part of our program because our families need multiple supports in different ways. And they may need additional nutrition education that they didn't receive because they're living in a place that wasn't where they learned how to feed themselves and move their bodies in a healthful way. So how can we give them more support to meet them where they are? Sometimes we're folding in additional supports. Sometimes we're folding in additional treatments. I think some of the basic things are, a lot of the work that we do is through interpreters. We work really closely with some food banks that are local to try to address some of those additional barriers as well.
Yeah. So recognizing food deserts and other economic sort of factors that also might just be impacting like a refeeding protocol for some families. Yeah. Sorry.
I'll just add to that, just to say, also with working with religious leaders for communities as well, who also haven't historically fit into the kind of very stereotypical idea of what an eating disorder looks like. And they have been instrumental in really helping to get buy-in from communities, from families in particular, and to help, I think, ease sometimes when there is tension and when there's kind of a historic distrust of healthcare providers for very valid reasons that can help in aligning both the providers and the patients and families with the care.
Yeah, absolutely. Absolutely. And I think some of those things that you've mentioned about the social determinants that are influencing care are so critical. And then also the biases we have as providers of what we're anticipating eating disorder presentations to look like, who we believe like folks who have eating disorders look like and sound and all of those things. I also am curious, have you found of any barriers in terms of the provider side? Because then if it's asked and answered, and then I don't know what to do, then like what happens then? How much just limitation of resources, training on the provider side become a barrier? What's your sense of that?
It's massive.
Took the words right out of my mouth. Massive. Yeah.
It's massive. I think thinking about resources and eating disorder care resources are limited. And even for our most resourced patients and families, getting really good care is a hurdle. It's right. It's can take significant amounts of time, significant amount of money. A lot of FBT providers don't want to take insurance. These are out of pocket and they already have wait lists. And so when you think about the line of patients who are trying to get care and what resources they have to be able to access it, there is not enough specialized providers to provide care for all the patients who are suffering.
Yeah, I think to address that, because my initial response is bring them in. Let me every time I hear, and I'm sure this happens for you all the time, of like, you get a patient who like their doctor was like, oh, you're obese or you're overweight, so you can't have an eating disorder, or don't worry about it. So you're vomiting. No big deal. You're still fine with weight wise. And so my urge is always to be like, just come to us and come see our adolescent medicine team and our whole integrated care team. And unfortunately, there's not enough. We're working to expand our services in all of those ways. And we're working to expand. And that's one way that we're targeting that. I think we're also working, Alexis and I do an awful lot of training. I think every time we're invited to speak to residents, to fellows, to pediatricians, we're signing up for those things and saying yes. And so we're going and we're talking about and working to dispel this. It is actually National Eating Disorders Awareness Week right now. She had excellent timing. And so like we had a table in the hospital and like we're handing out pens and having conversations with folks about that, doing outreach events. I think we're very lucky that Montefiore is supportive of those things and gives us the ability to participate in a lot of those educational activities, both at the provider level, at the training and teaching level, which I think is really important, as well as at the community interfacing level as well. Practically in the moment, for folks who are working with these patients, I think it's a lot of us doing the psychoeducation. The Academy for Eating Disorders, or AED, has a lot of really good resources that you can provide. If I'm ever working with a pediatrician or a physician who is not eating disorder trained, they have a great resource. It's called the AED Medical Guide, or Purple Book. So if you Google it, it's the Purple Book. I'll say, hey, I'm working with your patient with an eating disorder. Can we get on the phone? And I'll talk a little bit about like weight bias and general psychoed if they'll give it to me. And then like, here's this resource. Please pull the labs on page 8 and 9 and then interpret them for me so that we can figure out how we're doing this moving forward. We also work a lot with schools, also to counter some of the barriers to care. So we're working a lot with guidance counselors or teachers or whoever an advocate might be that may be able to provide lunch supervision for one of our kiddos. And that's another opportunity for teaching and training. And sometimes they're like, oh, hey, would you come talk to our staff? And I don't have time for that, but I'm going to make time for that because that's how we address some of these larger pieces and navigating those. So I think it's a lot of working with, and sometimes even nutritionists, just like an FYI, like a lot of nutritionists do not receive eating disorder training. So unless you specifically seek it out or make sure and see if someone there are some certifications that RDNs can have for that, or practice at a health at every size model, it can be helpful, again, depending on the age of your patient, to either advocate yourself or coach them to advocate, to ask some of those questions. And so I've worked with young adults and I've said, hey, you want to find an RDN to support you. I need you to ask about health at every size. I want you to ask about their eating disorder approach and training to folks with larger bodies. Like, I want you to ask some of these questions. And then I'm always available to provide additional kind of psychoed for my patients, particularly along the way.
Yeah. Yeah. It sounds like you've already really spoken to in a way that I think is so important to hear about how you are applying care in a culturally responsive way. You're thinking about what are the food choices that are actually going to work for this family within a cultural context? What are in terms of the economic resources, what is affordable and accessible for this family? If that's not sufficient, how are we leveraging community resources to fill those gaps? And thinking about how this may present in different bodies, different ways, different messaging around food for all sorts of different reasons. Are there any specific strategies or initiatives that you have found particularly effective in reducing barriers to care for marginalized populations?
I think one of the things that, in addition to all of the things that you summarized, Shane, and all of those things, I think one of the things is thinking about building effective relationships with our families. And so I think one of the things is when you are working with this patient population, it's so much about relationship, especially like we have to screen for food insecurity sometimes 3 and 4 times before a family's willing to disclose it because they're distrustful or they're fearful about systems involvement or the consequences of that, or there's shame there. So I think one of the big pieces is being willing to slow down a little bit. And again, Montefiore allows us to do that, and taking Medicaid allows us to do that in ways of we're really committed to building relationships with families. And sometimes the adolescent medicine team has a better relationship than we do, or the family is much more trustful of the medical system versus psychotherapy. And so one of the things that I love that we do, and I think this is good care, but also helps to address some of the barriers to care for marginalized families, is our treatment reveal. I know we've got one tonight where like mom has heard lots of messages about weight bias, is a little bit distrustful of the mental health field and system just culturally. And so we have, after 6 months of care, our adolescent medicine attendings, and they can't join this meeting and can help to reinforce some of the messages that we're sending of, hey, we actually do need continued weight gain. I know you're close and I know you feel better and I know you're eating, but we really do need to push the rest of those 20 pounds. And that is really integrated care as opposed to just collaborative care in a way that really helps to meet our families where they are in a different way. And again, that takes time, that takes resources that a lot of other places may not have, but that's one way that I think we are mindfully trying to tackle that. And not fair.
Yeah.
And it can be an uphill battle, right? I think particularly around weight stigma in our patients, people have been told forever, right, that being in a larger body equals bad, and that being in a smaller body equals good. And so when you're having to give the message that is counter to what we have been hearing as a society for so long from authority figures, from family members, from friends, from peers, and we're having to say, actually, you do need to be in a larger body to reach full recovery, and we're going to help you get there, and it's going to take time. It can be really difficult, and so having that partnership and that integration of care can make that message easier or take less time to sink in.
Absolutely.
I think one more piece that we think about, I think especially on the psychological side, but I know we're really committed to evidence-based practice, but also empirically supported treatments. And so again, when we're working with something that's so dangerous and deadly as eating disorders, particularly in peds, we know when kids turn 18, their likelihood of full recovery tanks. And the clock ticks as soon as you see us. So we're going to grab for those empirically supported treatments first. We're going to grab FBT, even though it was not normed and it was not developed with our patients in mind. We're going to grab the thing that science tells us is the most likely to save this kid's life and reduce their suffering in the long term. And then we're going to be flexible. So we're going to be flexible with infidelity. And I think that's a really important piece to do and to find support to be able to do. It's harder to do FBT with our patients and with our families, and we need to make adaptations. And those adaptations look different, to be honest, for every single family. And so some families were involving abuela, sometimes we're involving the neighbor, sometimes it's an older sibling, which usually we wouldn't do. Sometimes it's lots more family meals. Sometimes it's not involving parents at all. And we're thinking creatively before we pivot. But I think that's another really important thing of just because families have additional barriers or may not present in the way that the subjects in the randomized controlled trial did, doesn't mean that they don't deserve the same quality of care. And so again, we're really thinking about how do we maintain fidelity to things that we know work, to those tools and strategies and recommendations, and then be flexible to meet our families where they are.
Yeah. I'll also add, I think, coming in with an approach of there's so much that we don't know, right? And Lauren and I are always talking about this. There's so much that we don't know about our patients and their communities and their families, and learning from them and being taught by them about what works, what's appropriate, and not just on the small individual family level, but on a bigger level. For example, we have quite a large Jewish population, and having leaders from the Jewish community come in and teach us, right? This is what Shabbos means. This is what is appropriate in this setting, and this isn't in that setting, and being able to take that and incorporate it into our practice, and knowing that what works for one patient population isn't going to work for another one, and we are going to make mistakes, and how can we learn from those mistakes and do better?
Yeah, absolutely. And I can see that coming up so much. There's a lot of religious spiritual practices that incorporate fasting and things like that, I'm sure are, like important to think about. Just in my work in again with adults, like I work with a lot of people that are in medical residency, and that because they're part of the work culture of residency is doing 24-hour shifts, working incredibly hard, skipping meals is seen as like a virtue of your work ethic. And I think a lot of people can shield that within in a context where it feels like normative. So I think this idea of like understanding that cultural context and how the eating disorder functions is in that context, and how it's getting potentially reinforced in that context is really important. But then how do we, particularly going back to those, spiritual cultural values, how can they still be respected, valued, prioritized within within a treatment model? So I think the fact that you're doing that work and wanting to connect with community leaders is important in terms of the program design. I know that you mentioned, I think, which is so important, that this idea of the middle-aged white cis woman like being the poster of eating disorder has been such a contributing factor of misdiagnosis and underdiagnosis. I know you also mentioned that the different diagnoses within the umbrella of eating disorder is there. So I'm curious for you, in terms of things like ARFID, binge eating disorder, are you finding that there's underdiagnosis or misdiagnosis that happens amongst these diagnostic criteria specifically, or are there certain diagnoses that are more evasive and are under the radar more than others?
Absolutely. Yes. I think regardless of the barriers, that marginalized families and folks with various intersectional marginalized identities may or may not experience, I think misdiagnosis is really prevalent. I think a lot of a lot of our ARFID kiddos come to me, and the first 2 sessions are just parents crying that they didn't know what to do, and that you're not a bad parent, and there's a name for this, and you've been to GI, and you've been to speech, and you've been to the ENT, and you've been to like all of these different places, and there's a name, and you're not a bad parent, and we actually have a treatment, and there's hope for this, and thinking about it. And then I think the other piece is sometimes we don't know. I actually have a case right now that was just referred through adolescent medicine that I'm not sure if this is anorexia or primary OCD or ARFID. I'm just not sure. And a lot of the times we need to move forward with treatment anyway, right? Weight restoration is needed when we get through some of that physiological distress and we get them normalized and increase weight. It usually comes out and we can figure out some of those different pieces. So I think that happens a lot. I think there's also a lot of misdiagnosis with folks who are gender creative or in a different gender spectrum as we navigate what's an eating disorder behavior, what's a gender dysphoria behavior, what's both, and thinking about, does it matter at this point where we're putting a treatment plan together to address that highest priority target, and then we're keeping those things in mind as we go. I think same thing with binge eating disorder and emotional eating and what our binge is, right? I think a lot of this comes back to weight bias and diet culture of what an objective binge is. And I think even a lot of diagnosticians, like psychological diagnosticians, have not actually looked at what the definition of a binge is in the DSM before they're moving forward with that. And I think when that happens, we're again sending messages that actually exacerbate sometimes a restrict binge cycle because we're pathologizing behaviors that if we could actually help normalize as clinicians and actually help take some of the pressure off and say, okay, calm down. This is important to you. We're going to figure out a solution. We're going to go slow with it. But I also want you to know that you're not on fire versus we are on fire over here. Right. And so I think that's a piece of this that is difficult and challenging to know. And again, I hate to keep coming back to collaborative care, but when I have a patient that comes to my office, unless they have had a full medical workup, I know nothing about their health status. Sometimes I can tell based on a growth chart. The growth chart and information I can tell, but every time I don't know because BMI's doesn't work well for everybody as a health indicator. And so unless I'm working collaboratively with a medical professional who can pull labs and say, actually, these labs don't look so great. We actually need to shift over here and, oh, here's the fire. We found it versus not.
Yeah, I think that's a good segue to think maybe about what do you both see as the systemic barriers that perhaps mental health and medical providers could be working in concert to address more effectively. And I'm sure that's like a very long list, like a CVS receipt or something. So I may not have time to cover all of those sort of areas for optimization, but if anything sticks out or comes to mind as maybe some priorities.
I think we have to fix racism first. I say that facetiously, but it really underlines everything, right? Yeah. And how we treat people that are different from ourselves and from others in our communities, and the lack of funding into research and the lack of funding into treatment programs that look to take care of patients who come from diverse backgrounds and diverse populations, I think is one of the biggest ones, and unfortunately really difficult to combat.
Yeah, absolutely. And it's just in this climate in the US where there's so much political backlash on DEI, I think this idea of really misinformation of the not really being able to hold that the erasure of diversity from research, from clinical care. We already know what happens. I think your program and the ability, the attempts to rectify it, and like trying to fill these gaps of something that probably feels like quite overwhelming and try to work backwards and reconstruct it from why we're trying to serve patients. And it's just like a real cautionary tale when people are excluded, then they're subjected to these really horrific health disparities that are so hard to correct and take so much collective effort to correct. Yeah, I think that it's a tough climate when it sounds like you're trying to build momentum to create more inclusive programming for sure. Any sort of additional thoughts from you on that?
Yeah, believe fixing racism would be great and a great place to start. I think, especially if we look at a lot of the anti-fat bias activists that are out there, a lot of them are genderqueer, a lot of them are folks of color. And there's a lot of roots of weight bias in racism. I think thinking about how a lot of these things that we're talking about are very interconnected. So I can't co-sign Alexis's first point enough. I think practically a big piece in the eating disorders world is access to levels of care. There's a huge socioeconomic disparity. Again, even folks with commercial insurance versus public insurance, this is something we deal with a lot of. Eating disorder care requires willingness and commitment to be done at the outpatient level, or it requires family resources. And I mean that in terms of like time, energy, availability of food, those things. And so a lot of our families don't have those. And so I think one of the things that's really difficult is that's where higher levels of care come into play. And I think we think about higher levels of care in the eating disorder world a little bit differently than in the general like psychotherapy world, where patients actually need more scaffolded support for things like meal supervision and eating. And I think community can be really important. Eating disorders are incredibly isolating. And so things like residential care, things like partial hospitalizations, things like IOPs become exceptionally more important because we can't hit those weight goals. We can't really do anything else until we've got a brain that's fully nourished or as close to fully nourished as we can. And higher levels of care, I think, and stepping down through them are essential. And so I think one of the things that we think about, and in terms of advocacy and access, is access to those things. And there are some really great ones out there, but our Medicaid patients don't have access to them. And so all they have is access to outpatient services. And again, we provide, I think, a little biased, it's our program, really good wraparound integrated care. And that's all they have at the outpatient level or medical inpatient. And so now we've got somebody who's 75% of their expected body weight, and they're being discharged to outpatient care, where FBT, in the best of circumstances, is not started until someone's 85%. And so now we've got a family who is supposed to be doing a really intensive treatment that's supposed to be relatively short term. FBT's very aggressive, but relatively short term. But now you're doubling, you're tripling the length of that. And that's not how it was meant to be used. We're burning out our patients and our families, and it's not successful because it's actually not indicated at that time. And so then we think about things like family burnout and dropout and things like that. So I think access to care and levels of care is really important. Again, we're really lucky at Montefiore. Montefiore is behind us 100%. And so we're working on building a PHP. We're working on building an IOP. On the pediatric side of things, we're working on that. But I think that's a big piece. I say this a little bit facetiously, but also very true. I think we need to give pediatricians more than 15 minutes for a well visit and expand access to preventative care, because more than 50%, I would say, of our patients, our pediatric patients, started to lose weight or to change their diet in ineffective ways because a medical provider told them to. And that wasn't because I don't think that medical provider wanted them to have an eating disorder, but nutrition counseling takes time.
Yeah.
And it requires knowing a family and being understanding, okay, eat more vegetables. Like, where's that family going to get vegetables? And so if you tell kids to cut out things like sweets and candy and sugar and increase your vegetables, but if the family doesn't have a way to increase fresh vegetables and they just start cutting out things, now we're shaping, and then they get oh, you lost 5 pounds. That's great.
Right.
Like, keep it up. And again, this is like in a 15-minute well visit. You can't go into that you're double, you're triple booked. I'm not a pediatrician, but. So I think there's also a piece of we need to provide our primary care providers with additional resources to be able to do their job in a way that I think they would want to practice.
Yeah.
I've never talked to a pediatrician who said, I'd like to spend less time with my patient. Yeah. I think there's also advocacy level things of right now we can't bill Medicaid for nutrition support. And so if we're providing nutrition support to our patients, it's that no, we're not able to recoup any of their costs. And so some of those things are advocacy things that are happening at greater levels that we strongly encourage. to be able even to get Medicaid to be able to reimburse for nutrition. Because again, could we get a nutritionist in a pediatric office? That'd be great. Why don't we have that? Because it's really hard to reimburse for some of those services. And so I think some of this is the structure is actually thinking about changing some of the structures of the healthcare system to support patients, both in a prevention way and in an early identification and treatment way.
I was going to say, I feel so incredibly fortunate, right? In adolescent medicine, I get 30 minutes for a follow-up visit, but I have the flexibility to see my patients weekly or see my patients twice a week to be able to dedicate that time. And I'm not doing primary care and I'm not doing a lot of that preventative work. But again, we see patients for a variety of different reasons, and they all live in bodies, right? And they're all hearing messages from all different ways. And so being able to spend time with a patient that perhaps you're following for a menstrual disorder and then picking up, right, that perhaps their weight has plateaued, or that, that what they're eating has shifted and they're worried about it, or their families are worried about it, and being able to spend that time is really incredibly special and wonderful. And then the last thing I'll add, I know Lauren brought up when talking about racism and systemic problems of activists, right? And really leaning on and learning from people who are doing amazing work. And there's so many resources out that are helping to inform and educate people on how to provide care for everyone and anyone, regardless of where they come from. And just to name a few, I think Dr. Sabrina Strings at Santa Barbara does amazing work on fat bias, particularly within the BIPOC community, and Gloria Lucas with Nalgona Positivity Pride. These are two of many amazing programs. And I know we also have amazing community organizations that we work with that are able to help teach us and help us to take care of patients.
Yeah. Can I test it? We also have Sonia Renee Taylor.
Yeah.
We've got Sabrina Strings, Roxanne Gay. There's lots of folks who are doing really good activism work. And I think being mindful of how we amplify voices from some of the most marginalized and get behind their messaging and support them and follow their lead, and being in collaboration and community with those folks too is really, really important and crucial to doing this, to doing it in an anti-oppressive way as we move forward.
Yeah, absolutely. I think you both spoke to these massive structural barriers that eating disorders care is up against, including institutional racism. And it really sounds like you are both an integral part of such a important program through the eating disorders program at Montefiore. And there's just such good work being done there that sounds like it could be really important templating for potentially other programs in the future. So I think that's the piece that's hard, is we can feel really crushed and buried under all of this systemic oppression. And I think it can be very easy to be like, it's not possible in this client, in this environment where we're building on a foundation that's like rooted in injustice and oppression. And I think you're finding these cracks and these windows where the light can come in and build off this hopefulness. What gives you both hope about the future of eating disorder treatment, and what are you looking forward to in terms of continuing to do this work?
I think one thing I'll say to I think that point of, and I appreciate your metaphor of letting the light come in. I think the other piece is generating light yourselves. And so I think Alexis and our Alicia Hoffman's our program coordinator, who's not with us today. But I think like we generate some light. Like sometimes it's and like strobe lights, and like sometimes it's natural light. But I think some of it is the passion that folks have who do this work and who are signing up to do this work, who sign up to do this work at Montefiore with us. When you've got a group of providers, patients, and families who are dedicated to this and doing it, and it works, right? I think that's the big piece of our patients get better. And that's awesome. And that's really exciting. And it is, in fact, hard. But when you've got folks who are committed to doing the same things alongside you, and I can't always, if I'm having a rough week and I'm like, Alexis, like her light. And then sometimes it's Alicia's light and we're supporting. I think, especially in this climate, it's gotten a lot harder. I will say my families are now worried about leaving their homes because of some of the pieces there. And so they're not coming to appointments. And so guess what? We can't talk about you eating more if we can't talk about and help figure out how we're going to get food into the home. If parents aren't able to come or don't feel safe coming to appointments, or we're doing some of those things. And it is harder. And I don't want to pretend that it's not. And we've got an army of awesome people, a lot of whom are women, just as I'm thinking about that, who they let us be in charge, which is cool and a little crazy. And this is how our hospital system is dedicated to moving this program forward.
Yeah, it's funny you brought up, Lauren, about our patients do get better. And just the other day, I got to graduate a patient, and we were talking during our appointment about how in many other fields in medicine, there's fanfare, right? There's in cancer recovery, there's the ringing of the bell, right? When you complete treatment, and there's parties and there's celebration, and there's a ton more awareness and funding and community stuff. And I think we're hopefully changing that as we're developing more research and we're developing more community organizations and partnerships. But being able to have a little party when you've taken and seen this patient who you first met truly in crisis, right? Lauren talked about the crisis during FBT, and you have had really dark times, and there can be really challenging times during eating disorder recovery where in many ways in eating disorder world as providers, we say we have thick skin, right? We're used to being the enemy in a lot of the time, and that's as a provider. And to be able to walk through all of those dark times and be able to see the other side and to see this young person thriving, right? And to celebrate that is so special and amazing. And that gives me hope every single day, because I've now, again, we're early in our careers, but I now have this collection of patients who have fully recovered, and I don't know where they are, and that's amazing. And I don't know what they're doing, and that's amazing. And I also have a collection of patients that, haven't recovered yet and who mean the world to me and have taught me so much about being a doctor and so much about being a provider. And I will continue to walk beside them until they don't need me anymore, or until they unfortunately graduate into the adult world, and I'll be by their side no matter what, like even then. And that keeps me going, because there's so much love.
Yeah. Sounds like the relationships that are developed are just really special and probably really important to those recovery, efforts and building trust with the family. As you said, as you talked about, whether it's immigration legislation that is creating so much fear right now, or historically child protective services being overutilized in BIPOC communities, but right, like there's earned distrust, right, of healthcare systems. I think that you both are coming from such authentic, genuine places. With time and perseverance probably comes through, and building that trust, I'm sure, is so critical.
And one more thing to add, I think practically two things that give me hope are the folks who are doing amazing research in collecting data in this field, especially on the intervention side and a lot of the mechanism side to develop more transdiagnostic interventions, to do some of those things. So there's a lot of really great research that is coming out. And it's really exciting. There's some work in the coming out of, I don't remember which, like deep South state about app-based interventions and prevention programs. There's a lot out there that is continuing to come up and working. That's amazing, especially on the prevention front of things, which is awesome. The other thing that's really exciting to me and giving me a lot of hope is the integration of folks with lived experience into program development and into the research world. I think we lag behind some other fields and some other subsets of psychology to do that. And I'm really excited that that's happening also. And there's a lot of folks with lived experiences who are activists and who are getting involved and being supported in their work to change the field and drive it forward in a way that is promoting justice and equity in that way too. So.
Amazing. Thank you both so much for being here, for your time. Can you tell our listeners where they can find you, more about your work, more about the incredible work being done at Montefiore? How can they just learn more? I'm sure they're just chomping at the bit to learn more after this great conversation.
We have a website that needs to be updated, and we're working on it. But if you just Google Eating Disorder Program at Montefiore, we're there. It's a work in progress, and you can learn about us that way. And then if you're looking for more resources about eating disorder care in the area that you're in, if you're not in the New York City tri-state area, there are so many amazing organizations out there that are doing the work, and we call many of them our partners and have good relationships with them. And I can say a few and then I'll turn over to Lauren, but I think NEDA, the National Eating Disorder Association, is amazing. Project HEAL is amazing. And there's so many others. Feast, Lauren, I'll let you add to that.
Yeah, I think Peace is a great one, especially for parents and caregivers. Again, not all patients are ready or at a place where they're ready to get treatment, but Peace is an acronym. Love acronyms. Families Empowered and Supporting Treatments of Eating Disorders is that acronym. Also Googleable to find their stuff. Alexis and I are also happy to, if folks have questions, we do lots of consults. We do lots of teaching and are happy to do that. And if we can't, we've got an army of really awesome colleagues who are jumping in to do that work too. If you are in the New York area and folks are interested in referring patients to us, I'll just quickly say that our referral line is caregiver initiated. So caregivers or patients over 18 can give us a call at 718-741-2386. And that's the best way to get in contact with our program coordinator who does a phone screening and initiates the process. And that's a central referral line for all of the services and integrated care that we have at the Eating Disorders Program at Montefiore.
Thank you so much for your time. Thank you so much for being here and just, sharing your wisdom and the great things you're doing with our audience.
Oh, thank you so much. It's been our pleasure.
Absolutely.